You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for August 6, 2021. This week, COVID, vaccine-induced myocarditis, heart rhythm news, the state of medical evidence, and doctors in unions. Sadly, the Delta variant spike is in full swing, not just in the US, but in other countries as well. Our ICU went from 1 to 2 COVID-19 patient average in early July to 12. Like, boom. This occurred in only a week. My hospital's in a medium-sized city, but our system runs hospitals in rural counties. They've been even under more pressure due to the smaller number of ICU beds and higher percentage of unvaccinated adults who have risk factors. And on my EP messaging group, multiple other cities are experiencing the same rapid surge. States and cities with higher vaccination rates are faring better. I had a chat with our ICU doc on the COVID service. He told me that our ICU is 100% unvaccinated and 100% of patients with risk factors, primarily obesity. He also said that while he's seen some vaccinated patients get hospitalized, none get sick enough to make it to the ICU for pneumonia. He also noted the change in age range. Now it is younger patients, ages 30 to 60 in the ICU. The logical conclusion is that the higher vaccination rates in older adults have changed the demographics of ICU COVID. This is exactly what the original trials showed. The vaccines protect against severe disease. It sort of transformed SARS-CoV-2 into a far less virulent virus. You hardly need a cardiologist to tell you the solution. The solution is to increase the rate of vaccinations among adults, especially those with risk factors. Then, of course, if we are ever going to have a normal society again, we must figure out how to coexist with endemic SARS-CoV-2. Now, two other quick comments. One is speculation, the other a note on booster shots. My speculation is that the rapid rise of cases, surely due to the increased transmissibility of the Delta variant, and the global situation where most of the world's population remain unvaccinated, and now the evidence that there are clearly animal hosts for SARS-CoV-2, I read even deer have SARS-CoV-2, means that no matter how hard we try, everyone will eventually be exposed to SARS-CoV-2. I read from a Hilda Bastian tweet that even Australia, with their strict tracing and quarantine measures, mystery cases, quote-unquote mystery cases of SARS-CoV-2 have been noted. And if I'm right about not being able to evade exposure to the virus, this means that there's a binary choice. You can be vaccinated or you can take your chances, because I don't think avoidance is going to be an option. Now, of course, I wish more at-risk folks took the vaccine. But in the same way that people smoke and eat too much and don't take their meds, some will choose not to get the vaccine. I hope the vaccine hesitancy amongst people who clearly shouldn't be vaccine hesitant causes a candid reassessment of the messaging and politicization of medicine and science. I am not taking political sides, and I'm not saying it's easy, but to me, messaging on medical evidence and public health ought to be as humble, politically neutral, and as open as possible. Trust is critical for persuasion. Now, speaking of medical evidence, it boggles my mind that many of my colleagues are openly saying they have or plan to have booster vaccinations based on a preprint that measured declining vaccine efficacy. I see 3 reasons why this is nuts. First of all, there's no data on the efficacy of boosters. Vaccine efficacy against severe disease in that preprint, I looked at that preprint, remained at 97%. You don't know if a booster is necessary nor safe. Now, I bet it's safe, but you don't know without outcome evidence. Remember, the myocarditis-like signals are not easy to detect in trials. It's also terribly selfish and unbecoming. Imagine the view of most of the world where vaccines aren't as available. Huge swaths of humanity can't get any access, and rich, mostly low-risk doctors are bragging about getting extra shots. Now here's the thing you learn from cardiology clinic in flyover country. Regular people see stuff. They see entitled, connected people who on the one hand speak and write and tweet about leveling global disparities of health access, but then go out and procure available doses of vaccine for themselves, an act that probably contributes to disparities. Such behavior shreds public trust. Now, the third reason this is nuts is that it doesn't slow the development of variants. In fact, it may increase the spread of variants. This is because the virus can spread and mutate in large groups of humanity that don't have access to vaccines, and a variant that forms on another continent could easily travel across the globe. Now, the final thing, the caveat on boosters, is you can make an argument that it most fits for the immune compromised. But again, this too should be studied systematically. Vaccine myocarditis and pericarditis. JAMA published this week a research letter on myocarditis and pericarditis post-vaccine. It's both good news and bad news. First author, George Diaz, and others from the Providence healthcare system reported on clinical records of 2 million individuals who received COVID vaccines. Now, these were adults. The incidence of myocarditis, 10 per million. 10 per million. It occurred 3.5 days out from the vaccination. 20 cases, 15 of 20 were in males. Most cases occurred after the second shot. 19 of 20 myocarditis cases were admitted. Now, the median age was at 36. All of these patients were discharged. There were no deaths. The incidence of pericarditis was 18 per million. It occurred a little later, a median of 20 days out from the vaccine. 27 of the 37 were male. Slightly more of the cases occurred after the second shot. The median age here was a bit older at age 59. 13 of the 37 were admitted and all were discharged. Now you might wonder what the rate of myo and pericarditis were before vaccines. For myocarditis, it was about 16.9 per month pre-vaccine and 27 per month during the vaccine period. The p-value was less than 0.001. And it's the same relationship with pericarditis. There's significantly more of these during the vaccine period. Now recall a little bit ago that the CDC recently reported an association between COVID-19 messenger RNA vaccines and myocarditis, primarily in younger male individuals within a few days after the second vaccination. The incidence there was 4.8 cases per million. So the authors of the recent JAMA article write, quote, "This study shows a similar pattern, although at higher incidence, suggesting vaccine adverse event underreporting. Additionally," they write, "pericarditis may be more common than myocarditis among older patients." So the bad news is that the messenger RNA vaccines can cause cardiac injury due to inflammation. The good news is that it appears to be a very low incidence, and in these cases the condition resolves without serious complications. Again, if I were a public health leader, I would state clearly that these are real findings. The vaccine can cause cardiac injury, but it is rare, and for adults, especially those with risk factors such as obesity, the benefits of vaccination far outweigh its risks. And I stand by my earlier column on younger adults and adolescents, though. Here the risk of SARS-CoV-2 is far, far, far less, and different people can feel differently about the harm-benefit calculus of vaccinations in young, healthy people. Okay, heart rhythm news. The Heart Rhythm Society actually pulled off a partially in-person meeting recently in Boston, and I just wrote a column about it. Bottom line, despite 16 late-breaking sessions and 1,000 more original abstracts, I found no real practice-changing science. The two hottest areas of EP are pretty light on evidence. But you all should know about a potential new energy source for ablation in the atrium. It's called pulsed field ablation, PFA, pulsed field ablation. It works via electroporation, a technique that involves applying electrical current to the heart, which then disrupts current flow across the cardiac cell membrane, and this results in pore formation in the membrane and cell death. Now, the huge upside of PFA is its cardioselectivity. Sort of miraculously, it does not harm the adjacent phrenic nerve or esophagus. It's also fast, and rapid electrical isolation of pulmonary veins means patients will require less anesthesia. So it's quite exciting to see the images of ablation occurring in the LA and no damage to nerves and the esophagus. But I have two main areas of concern with the PFA. First is safety. Intracardiac echo reveals huge amounts of microbubbles that occur with PFA. This raises the concern over cerebral microemboli. Right now, there's a dearth of brain MRI data in cases of patients who've had PFA. And in the column I wrote, I mentioned an abstract from Dr. Andrea Natali himself, in which transcranial Doppler in 6 patients who had PFA revealed concerning signals of microemboli. Now, the other issue with PFA is efficacy. I worry that the speed and ease and cardiac selectivity of PFA will induce doctors to ablate more left atrial tissue outside the pulmonary veins. Now, this may or may not be wise. We need outcome and safety data on this new technology. A second topic of enthusiasm in my field is in the area of pacing the area of the left bundle branch. You might wonder, wait, how do you get a pacing lead near the left bundle branch? Isn't that over in the LV? Or you might wonder, why would you want to? What about His bundle pacing? Well, my friends, despite its sheer beauty, His bundle pacing has some downsides. It's hard to do, the sensing can be low, thresholds high, and of course that means pacer generators may not last as long. Left bundle area pacing is not quite as hard. It gets better sensing and pacing numbers. And you do it by moving the lead south on the septum a bit, and then you screw the lead through the septum to the other side of the septum where the fascicles of the left bundle branch reside. And this allows capture of the left bundle branch. You want this because activating the left bundle or the left side of the septum preserves normal left to right septal activation, and it avoids delaying contraction of the LV. LV contraction delay is the problem with left bundle branch block in RV pacing. Delayed left ventricular activation is the entire reason for biventricular or CRT pacing. But here's the problem with left bundle branch area pacing. It requires a learning curve. It's a new technique. We don't have long-term data on the pacing lead performance, and we have no outcome data. And I discussed this issue in the column. A study presented at HRS, it was a late breaker, it tried to give us outcome data. But all it did is simply compare patients in 2 hospital systems who got left bundle area pacing to those who got a standard RV lead. And I know regular listeners will know the problem. You can't do that and expect to get an unbiased comparison. I mean, if you want to know how 2 pacing techniques stack up, you must randomize patients. Randomization balances out all the known and unknown baseline characteristics. When you compare without randomization, you always get a biased sample. That is because a doctor chose to use the new or the standard technique. And indeed, as I wrote about, the study showed that left bundle branch area pacing crushed the standard pacing. But it surely was biased, and I know this because left bundle branch area pacing reduced mortality by about 50%. And no proponent of left bundle branch area pacing would suggest that it is that good. So of course, sicker patients received the standard RV pacing lead, and that is why they did worse. Now, there were a number of potentially nice papers presented at HRS. So few, though, had simultaneous publications, and it's hard to evaluate a slide presentation properly without a published paper. And when these topics come out and the papers are published, we can revisit them here on the podcast. The next topic today is on medical evidence. A research letter published in JAMA Internal Medicine, first author, Todd Lee from McGill University. It exposes the lack of rigor in the adjudication of science, and this is not a good news story, but it is an important story, and I think there's an important take-home. The research letter tallied the number of citations of a retracted study. Remember back in May of 2020, during the height of the pandemic, New England Journal of Medicine published a paper that showed no increased risk for in-hospital death with the use of ACE or ARBs in hospitalized patients with COVID-19. The data came from a nebulous database called Surgisphere, and interestingly, internet sleuths and Twitter scientists, not peer reviewers and editors at the top medical journal, proved that the data was broken, fraudulent, and within 6 weeks, New England Journal of Medicine retracted the paper. And a week later, another study from the Surgisphere database, this one on hydroxychloroquine, was published in Lancet, was also retracted for the same broken, fraudulent data. The Canadian research team was interested in whether the retracted New England paper was being cited. And the sad answer was that over the past year, yes, 934 published papers cited the obviously debunked study. And of these 934, 652 were verified citations in peer-reviewed journals. Most of the citing articles, more than half, were published 3 months or later after the retraction. About a third were published 6 months or later. And in May 2021, nearly a year after the article was retracted, it was still cited 21 times. And here's the worst part. The citations were not only used to support an argument, but in 17 papers, the data from the retracted article was incorporated into a new analysis. Let me repeat. There they sit for anyone with a computer connected to the internet to find 17 papers that include known fraudulent data. My friends, this is such an important research letter. The take-home message should not be cynicism, though I understand how you could get there. Instead, this work amplifies the necessity for keeping and embracing skeptical priors about medical evidence. Always remember that science is hard. Magic bullets like the messenger RNA vaccines and insulin, these things are rare. The incentives of science publishing is the same as media. It's attention. In the same way that we consider dualities of interest in industry-funded studies, we should also consider the incentive structure of science. The retracted studies got by peer and editorial review because they were attention-grabbing in their content and in their findings. When we consume science, we must remember that more mundane studies, or those that find non-significant results, are more likely to remain in the file drawer and never be seen or published. Good science that finds non-significant results may receive this common message. Quote, in comparison with the many other papers we have to consider, this one is a lower priority for us. Maybe you've received a message like that from a journal. The purpose of This Week in Cardiology, this podcast, is to promote critical appraisal. I like to think of it as the neutral Martian's view of evidence. To do critical appraisal, you have to approach science done by humans with a skeptical but not cynical prior. And I thank you, Todd Lee and colleagues, for reminding us of this important message. The final topic today is a feature article. My colleague, Melissa Walton-Shirley, wrote a provocative opinion piece on why and how doctors should unionize. Gosh, this topic provokes deep thought about the role of doctors in the current state. And I have such mixed feelings. I really encourage you to read the piece. Think about this issue. I've done this job for 20 plus years. Even though I've never felt more expendable, I still love doctoring as much now as when doctors actually controlled the hospital. That said, I wonder if the health of patients might not be better off if doctors hadn't ceded control to administrators. I see a lesson from the Tour de France. The most successful cycling teams sacrifice personal goals for the team. If any member of their team wins, they all win. So I see the most challenging part of getting doctors to come together for the greater good is that it requires that same sacrifice. And I haven't seen that. We aren't good at that. I think perhaps because the same drive that gets you through the rigors of medical training works against coming together. When I was in private practice the first 10 years, it was very common for a policy that would have benefited the group to fail to reach consensus because of personal goals of a few. Now, imagine that on a grand scale. Like I said, read Melissa Walton Shirley's piece and think about this topic, especially if you are a young clinician. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And friends, remember, if you like this podcast, please take the time to give us a rating. Write us just a sentence or two review. That helps others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.